So sincere welcome. Thanks to Dr. Wafaa El-Sadr for being here today, joining us as the third speaker in the Commissioner's Grand Round series. As a reminder to all of you here and to everyone watching online, we created this series which asks us to engage with the practical, scholastic, and key policy and programmatic challenges that face the health of our city and of our nation as we emerge, and our world, as we emerge from the worst public health crisis in a century. It's also our effort to get our staff, our health department staff, our public health leaders across the city, and really beyond, engaged and re-engaged in the issues and the discourse that make us all so proud to work in public health, and explain why we came to this work in the first place. I think we haven't really had a chance over the last several years to be as engaged as this series hopes we can be. So very pleased to have Wafaa here. Before I dive in, I want to take a moment to briefly share a little bit about my time last week in Geneva. I had the pleasure to attend the 76th World Health Assembly, which was, as you know, is the meeting of member states of the United Nations to establish the global health agenda for the coming year. And this particular meeting was important because it was also celebrating the 75th anniversary of the creation of the WHO in 1948. We were the only city representative invited directly by the Director General. I think this is very much a recognition of the unique role that New York City plays in the world, in influencing global public health, whether it's been our TB programs, our HIV programs, our work on tobacco, and now more recently on COVID. The world has really looked to and continues to look to New York City for guidance, from real feedback from the ground, for innovation, and for leadership. And what's really important is also that we were there, yes, to represent New York City, but we were also there on behalf of cities. And this Director General, and I think a lot of us, having been through COVID, are recognizing more and more with rapid urbanization, density, with infectious disease threats, that cities, in many ways, are going to be the leading lights of the future of public health. That nation states, and we've seen this even in our own nation state, increasingly have a difficult time organizing public health solutions, and that localities, cities in particular, have a really important voice and a very important role to play. We've seen that even with some of the organizing work that we did over the last couple of years. When I first started, we organized a sign-on letter with all the big city health commissioners for global vaccine equity, a letter to the G20 to say, if you don't ensure equity in the developing world, cities like ours will end up facing the brunt of new variants and new emerging health threats. So it was a real pleasure to be there. It was very important to be there also because, as you may know, the world is in the midst of a negotiation of a global pandemic treaty. Now, this is a very fraught set of discussions. Our own administration, our own government may or may not be in support of the treaty. We don't know yet, but it's never been more important to have global cooperation at a moment when we're seeing our countries fragment and atomize, and the old order of things coming out of the UN and coming out of World War II of global cooperation and understanding. When we're seeing that somewhat disintegrate, it's never been more important to come around some common understanding and common goals for pandemic preparedness. And so to offer our voice in that discussion, even on the sidelines of that discussion, not as an official delegate, but as a voice of one of the biggest cities and most important cities in the world, was very special. With that, we also were able to discuss other key health issues facing our globe: mental health, global migration and climate change and health, and so on and so forth, including things like trust and mis and disinformation, all work that we've very much led on. So I was very pleased to be there. There's more to come from this work. The UN General Assembly is coming, of course, back to New York in September, at which point there will be a high-level political meeting for the pandemic treaty. And I know that the WHO is interested in a strong partnership once again with DOHMH, and I'm very much looking forward to that. So it was an honor to represent all of you in that meeting last week. It's also a good segue to introduce my colleague, my dear friend, in many ways a mentor, Wafaa El-Sadr. We're so grateful to bring Wafaa here to be with us today. I've had the pleasure of knowing Wafaa for almost 2 decades. I met her when I was just starting out in one of my first jobs at WHO, and we were working on scaling up HIV treatment under the 3x5 initiative to get 3 million people on treatment by the end of 2005. And then, of course, we've intersected again at Columbia University over the last several years. So just very briefly, Wafaa is an infectious disease specialist, a medical doctor. She's the founder and leader of ICAP at Columbia University, which is a global leader in HIV and other global health threats and health systems development. She's a professor of epidemiology and medicine at Columbia and executive vice president at Columbia University Medical Center. She's the director of the Global Health Initiative at the Mailman School of Public Health. She's a member of the NIH Fogarty International Center Advisory Board, was a John D. and Catherine T. MacArthur Foundation Genius Fellow. I can go on and on and on. Importantly for us, and more recently, she's the director of the Pandemic Response Institute, which you see on the slides here. As you might recall, this was an initiative started but not really launched, started in the last administration, but not really launched until we started, which is a partnership between Columbia, CUNY, our health department, and EDC, to really bring a non-city collaborative view of how communities can organize for pandemic preparedness. And so we're very glad to be working closely with the PRI and with Wafaa and her leadership. Given her broad and deep understanding of infectious disease threats, health emergencies, and global pandemics, we thought this was a pretty important conversation to have, and you're an important person to have here to do it. So let's welcome Dr. Wafaa.
Good morning or good afternoon, everyone. Thank you very much for you looking tremendous.
Sorry.
Maybe I think you need some medical attention.
There may be some doctors.
There may be some. I'm infectious disease though, so but it's really a great pleasure to be here and honor. Thank you so much for a generous introduction. I can't tell you how much everybody counts on this Department of Health, and not just as a resident of New York City, but also in terms of everything you do has such a huge impact on people in this country and around the world. I mean, you are the flagship, really public health agency probably in the world. So it's really an honor to be here and having the opportunity to reconnect also with some new friends and some old friends. So thank you. So what I thought I'm going to do today quickly is talk about lessons for tackling public health threats and really sort of building on the lessons we learned from both HIV, COVID-19, mpox, and so on. I used to entitle these slides "Lesson Learned," and then I thought about it and thought, well, actually some of the lessons are not learned, but we tend to always use the term "lesson learned," but maybe lessons that we hope will be learned. So keep that in mind. I have no idea how to work this. It's very fancy. Oh, this one. Okay, so here's a very brief outline of my presentation. I'm just going to touch on kind of HIV, COVID-19, mpox similarities and differences. Talk a bit about the key lessons, again, not learned, key lessons, and then look ahead and then have a few conclusions before we have a conversation. So let me talk about similarities and differences. So let's talk about similarities first. And just to jump into it, I think everybody in this room will recognize that one of the things that really distinguish all of these conditions, whether they be HIV, oops, I did something wrong. HIV or COVID-19 or mpox, is all of them are distinguished by being associated with stigma and discrimination. And it's interesting to think about the they all have this characteristic, but for different reasons, and because these are very different conditions that affected different populations. So we know that, for example, with HIV, especially because of the very highly stigmatized, remain highly stigmatized populations that are most severely affected by HIV, including men who have sex with men, people who inject drugs, as well as also sex workers and others. So that's really what's driven a lot of the stigma and the discrimination as it relates to HIV. And then with COVID-19, we do know that there was, of course, particularly in the beginning, maybe more so, the issues around, of course, the discrimination and stigma that Asian Americans faced because of the erroneous association with such individuals in terms of COVID-19. And then with mpox, I think we almost relived the old days of the HIV-associated stigma because of the population, again, most severely affected. But I do think there were some important lessons that were learned, and I'll point to those based on the experience with HIV that I think were very helpful in tackling mpox. And I think the Department of Health here was really at the forefront of taking those lessons to heart in terms of responding to mpox, effectively to mpox. I think the other thing that similarities are realization that you need to have a community-driven responses. And this particularly I've learned is through my work in HIV of the importance from day one of engaging the affected population, the affected communities in very concrete ways. And I do think that what we've learned is that these communities have to be brought in very early in the response, have to be continuously engaged in the response from day one. And I do believe that one of the important legacies of HIV for health overall and public health overall is this concept of really vigorous and ongoing engagement of communities, affected communities in very, very fundamental ways. That never used to happen before, and HIV, I think, changed the paradigm of how we engage with affected populations. And I think then we saw the same thing in terms of engagement with COVID-19. And I think, again, even in our own community here, the importance of engaging the communities in the value of engaging communities, particularly in the response, particularly in reaching either disenfranchised populations, vulnerable communities, and engaging them in having access to the services needed. And then, of course, mpox very much mirrored what we have known before from some of these similar experiences with HIV. I think your commissioner mentioned the misinformation, disinformation, and this is something that I think we faced with all of these, and we will continue to face moving forward. I don't think we have exactly the solution, the magic solution, but you can see here that from the earliest days of HIV, way back, this is when Larry Altman, some of you will remember, Larry Altman used to write, maybe this audience is a very young audience. He used to write about HIV in the New York Times years ago, but even then there was a fact theory and myth of AIDS, and I think this very much resonates with everyone here in terms of what we've seen with COVID-19 and mpox. And I think this hasn't gone away. There's still misinformation and disinformation regarding HIV that need to be addressed. Of course, with COVID-19, that's where we faced a huge impact of the misinformation and disinformation that continues thus far in terms of whether it be in terms of the virus itself, the origins of the virus, very similar to what we heard with, it's almost a replay of what we heard with HIV actually in the early years, as well as with the measures to overcome it, whether they be treatment or the treatment itself, as well as other aspects of management of the condition. And then I think another is the disparities, and obviously you all here have done enormous valuable work in terms of shining a light on some of the disparities, whether they be in terms of HIV or COVID-19 or mpox. And we continue to see these disparities. When you look at new HIV diagnoses, these are data just very recently reported. And again, you'll see that disproportionate impact of HIV in terms of African Americans constituting And both Blacks and Latino MSM constitute about 74% of new HIV diagnoses, and we can talk about that in the discussion and why that's happening and what we can do about it. And similarly, we've seen the same in terms of impact of COVID-19 by race and ethnicity, data from the CDC, but also very valuable data from New York City here, and of course mpox in terms of diagnosis of mpox and amongst MSM in the United States. And we've seen similarly kind of the disparity in terms of diagnosis versus access to vaccination for mpox. I think the other thing is I wanted to touch on some global, because it's not only local, but it's also global. We see these disparities, and certainly in my lifetime, long lifetime with HIV globally, we've seen that in the early on, of course, the access to treatment was largely restricted to wealthy countries for years and years and years, and it was only the activists and their mobilization that led to expanding access to treatment to low and middle income countries. I think this is more or less what we're facing with access to COVID-19 vaccinations for this map. You see that in the darkest green are share of the population in percent in terms of being fully vaccinated with COVID-19. And of course, you'll see here very evident that the whole African continent lags behind and with low percentage of the population being fully vaccinated. And it'd be interesting to talk about the discussions at the World Health Assembly, because I think a lot of the motivation behind the treaty are issues that are evident in this map in particular. And then, of course, in mpox, as you know, many of you are aware, is that this is not a new novel virus. The virus that's been around for a long time, mostly in sub-Saharan Africa, certain countries in sub-Saharan Africa, but it only rose to the attention of the world when it started affecting more high-resource countries. And obviously, you can imagine the reasons for this, but to date, to this point, even to today, in many of those countries, whether they be DRC or other countries in West Africa, access to diagnosis for mpox is almost zero, as well as access to vaccine and treatment is also almost unavailable completely. Now, some differences here. I think what's interesting to me is, when you think about HIV versus COVID versus mpox, I think what's, kind of in the middle there is COVID, and this is just, you don't need to even see the details here. But I think the evolution, and this is just showing samples from neutralization of samples from participants in a vaccine study against different variants of SARS-CoV-2. And you see the variability in the neutralization effectiveness from the serum from these individuals who were vaccinated. And I do think that this is a part of the challenge with COVID-19 is I think it's the first time that we faced, and maybe you have some other examples you can think of, I think it's the first time we faced a pathogen that evolves so rapidly. Usually, we faced gonococcal infections, for example, that become multi-drug resistant, but this happens over long periods of time. So COVID is a particular challenge that I think we've never seen before like this. HIV, of course, evolves very rapidly as well in the person who's infected. But as you know, we don't have a vaccine we still don't have a vaccine for HIV. So this phenomenon of seeing this rapidly evolving virus like SARS-CoV-2 is distinctive, and I think it also, of course, resulted in a lot of challenges in the response itself, but also in many ways offers a lesson that we need to keep in mind potential other emerging pathogens in the future. And this is about the vaccines. And the story with HIV, people always tell me, why don't we have a vaccine for HIV? And it is truly amazing. There's work has been done in seeking a vaccine for HIV for the past 35 years. It's a long time, and it's not for lack of trying. But as you can see here, almost every vaccine study that's been done, or phase 3 large vaccine study that's been done for HIV, all of them have shown that this is not effective. So that's in and of itself is obviously very disappointing. And at this point, almost the field itself is almost retreating and trying to think about where do we go next. This contrasts sharply with, of course, COVID-19 and with mpox. Mpox, there wasn't a vaccine available. We're very fortunate to have had that. And then with COVID-19, the rapid development of the vaccine was incredibly useful, but also has opened the door to ways of developing vaccines much more rapid manner. I think another interesting difference that we've seen is the uptake of interventions. And you know, some of us somehow lament the uptake of COVID-19 vaccination, but actually, when you look at it, it's pretty good. We want to do better, especially amongst the most vulnerable populations and with the new bivalent booster. But nonetheless, when you think in terms of the population level here in the middle, the uptake of vaccination for COVID-19 was actually much better than what we've experienced with uptake of other interventions. And just as an example here that I want to point out is the uptake of pre-exposure prophylaxis PrEP for HIV, which is almost like a vaccine for HIV. We don't have a vaccine for HIV, so the closest thing to a vaccine is PrEP. But you can see, unfortunately, that here the increase of PrEP users over time in the United States really has been quite limited of the population at risk. And even more importantly, when you look at amongst the people who have started PrEP, prescribed PrEP, you see the stark differences also by race, ethnicity as well. So we have, fortunately with COVID-19, there are very valuable lessons that we've learned of how do you scale up an intervention. And sometimes I wonder why we don't do that for PrEP, for example. That is something to be discussed. Obviously, there are differences. Vaccine is one shot, PrEP is a pill every day. But nonetheless, there are important, I think, differences but important lessons. So I'm going to sort of go quickly through what I call 10 key lessons very rapidly that I hope we can agree that they should be learned. So I think the first one is waiting to act can cost lives. And we've seen this, and I'll give two examples here. One is HIV, and there's a long history of and documentation of how, for example, the delay in initiation of or introduction of antiretroviral therapy and acknowledgement of HIV in South Africa resulted in the most severe epidemic in the world in South Africa, and also the death of really hundreds of thousands of people because of that. I think also there's also been modeling that's been done here in New York City and elsewhere that has shown that, you know, even if you could have, for COVID-19, even if lockdown had been done 1 week earlier or 2 weeks earlier, the impact would have been profound. So this concept of waiting to act is sometimes can, in these emergencies, can cost lives. And I know it's complicated, but these are the issues we should discuss because it's not as easy as it sounds, but it's something to always keep in mind. I think the second lesson learned is that the importance of surveillance, and I'm sure that people in the room here, everybody does surveillance here, right? But the importance is that we always say you can't see what you're not looking for. And I think that's been a very important lesson that we've learned. And I think the value of global surveillance and for COVID and for variants of COVID was very important in the response to COVID. And I think now the whole arena of the importance of investing in strengthening surveillance and surveillance system is so profoundly important, whether it be for ongoing pathogens, but also for emerging pathogens. And I think the department is obviously involved in the wastewater surveillance, which I think in a lot of ways opens the door for opportunities for passive surveillance. I think another lesson that's important is communication, and this department has been magnificent at communicating, so thank you all. And finding new ways of communicating about these threats. And I do think that one of the important things is, and I think this is something that needs still to be discussed, is what is the best way to communicate, and who is the best communicator, and when is the best way to communicate. There's a science of health communication, and I think then there's a practice of health communication. I think these are areas that sometimes we didn't pay sufficient attention to. What I thought was interesting in this study that was published in The Lancet, I believe, a while ago, and that looked at preparedness in 177 countries. This is during from January 2020 to September 2021. And when they did all the analysis, the two factors that they saw were associated with lower infection rates and higher vaccination coverage were high level of government interpersonal trust. And trust is very important, and less government corruption. So. And trust is a very complex concept, but I think it gives us I think should inspire us to think about how do we as public health practitioners and so on, how do we work on building trust? What does that mean exactly? And how can we do it? And who can help us in getting to this level of trust that would then protect the population? As for stigma, it must be addressed, and I think in a lot of ways there have been a lot of interesting lessons that have been learned, and one of them is just the change of the name of monkeypox to mpox, for example, with the push behind by the activists and others. But I think in a lot of ways we often come to appreciating the magnitude of stigma when we look at the data and we see that there's a gap somewhere. We don't anticipate it early enough. I think we should anticipate it very early so we can mitigate it rather than having to go and try to address it thereafter. And then with coverage, I think very important is when we have a tool that works, whether it be a vaccine or a PrEP or any tool that works, we're never going to get the impact we desire from that intervention unless we achieve high coverage with high quality. And that's important because it tells us from day one that we always anticipate the tool that we're going to have at our fingertips. But then we start thinking about coverage and quality afterwards. And maybe what should we, before early on, be thinking about what if we have a tool? What if we have a vaccine? What should we have in place? Rather than waiting until we have the tool and then trying to think about how to achieve coverage at a population level and quality of the program. And of course, to achieve coverage means we have to reach, and that these interventions have to be reach the populations. I think, again, the Department of Health here has done amazing work in trying to, and that was evident during COVID-19 and mpox, and sort of really mobilizing to think outside the box. Where should we take the interventions to? How can we reach to the populations that need these our interventions, so that these interventions are within reach? I always say that really you have to not wait for people to continue. You have to go to the people that you need to involve, and that certainly is an important lesson. I think to anticipate and address the spillover effects, and actually I was very honored to write a paper with Commissioner Vasan and colleague Ayman al-Mohandis at the bottom right here, that looked at the whole issue of not just focusing on the pathogen itself, whether it be COVID-19 or mpox, but all the other spillover effects that happen, whether they be societal issues, economic issues, and so on, in terms of the livelihoods, housing, all the other effects that often, are not front and center when we're thinking about the response. And we've seen a lot of different types of spillover effects, and probably with COVID, for example, the increase in anxiety and depression and so on, the mental health crisis that's been noted. Another has been the increase in domestic violence, and these are data from different countries, France, Argentina, Cyprus, Singapore, other countries here, including the United States, that showed again this was an effect of the COVID-19 pandemic. And then, of course, the hardship in terms of the financial effects on people. And there are many, many, many more that you're well aware of: housing crisis and educational crisis and so on. So trying to think ahead, a priori, of what are going to be these spillover effects so that we can think about them and mitigate them as we are planning response. And then the front lines, I mean, the frontline workers, and I think that's very important. I feel like the frontline people always think of these as the clinicians, like the nurses and the doctors and so on. But also I feel that public health workers are part of the front lines, and community health workers and all the people who are out there doing the day-to-day work at a time when there was no vaccines or anything at all, is that often these individuals, it's almost thought that they are expected to keep going, but often they suffer because of that and really have had major mental health challenges. And then importantly is now, as you know, the whole idea of One Health approach is that we can't think of this solely, and I like this this figure here, is One Health means that you're thinking about, you know, the human health, the animal health, as well as the environmental health together. And we know that with climate change and so on, there's such disruptions in the ecosystem that now there's an increased risk of cross-species viral transmission, for example. And that brings us back to this importance of focusing on One Health. And this is something that we're really working on at ICAP at this point in time, to be thinking broadly rather than thinking on how these things affect humans only. And I think last one is, of course, the importance of equitable response. And this Department of Health is, all of you are very well aware of this. And I think that's something that I've learned from early on from HIV, but COVID-19 and mpox. It's something that's very, very important, and to think about as we're shaping and thinking about our interventions. So I'm not going to go through this, but these are my 10 lessons that I'm hoping will be learned. So what about looking ahead? I think it's important to think where we're at, and I think your experience with the World Health Assembly would be interesting to hear about the conversations. Because, you know, there's this metric that's been developed and has been used to measure countries and their preparedness. And as you can see here, that the United States actually, this was done before COVID-19. This was done 2021, okay? And there was a similar one that was done right before the pandemic started. And in both of them, the United States came out as #1 country in the world in terms of preparedness. And this is 2019. Here's the score for 2019. Also 1 out of 195. So either the metrics are wrong, there's something wrong, right? So this picture. But I do think that knowing what we know, we collectively can develop a better metric in a lot of ways, because it's impossible for me to imagine how we did, you know, on these measures we did so well. So it hasn't motivated the effort to try to think about, based on what we've learned, what are the real ways of measuring preparedness? This is something that we're interested in at PRI. We can talk about that later. But this tells me there's something wrong with the way we're measuring this, because it's like developing a model and then the reality goes in a very different direction. So it should have us think about how do we do this and how do we measure this so we can see how we progress over time. If you're #1, it kind of lets you be a little bit complacent. If you're #1, you can't be better than #1, right? So it's important to come up with something that's accurate, that actually truly measures preparedness. This is something that I wrote that had to do with HIV, and part of it is this idea of thinking beyond the magic bullet. There's often the temptation to want that magic bullet, whether it be a vaccine, or whether it be a pill to treat something, or an injection to treat something, or to prevent something. And what we've learned from HIV, and from others, and from COVID and mpox and everything, is that there is no magic bullet. And that ultimately, I think what's important is we need of course, the biomedical innovations and the biomedical, inventions like vaccines and so on. But very importantly, and it's at the same level of importance really, are the behavioral issues, is that we have to think, even if we have this biomedical miracle, we do need to think about people and how they make decisions about whether they're at risk or not. And what are the impediments they face in accessing services? How can we get them to be adherent to whether it be prevention or treatment? And then, of course, we need to think about the structural barriers, and this includes stigma and other structural barriers. And then ultimately, of course, we need to engage the community. So this kind of comprehensive approach is always important to keep in mind, because I don't believe there will ever be kind of a magic bullet in our world, in the public health world. I just wanted to end by saying a couple of words about the PRI, Pandemic Response Institute. I always have to remind everyone that although the word pandemic is in the name of PRI, we're really supposed to focus on all major health threats. It could be climate health threats, it could be pandemics. So the idea is to think about preparedness and response across the board against any major health threat that New York City faces. And I think the goal is to access to health solutions, information for decision making, capacity to prepare and respond. And as you heard, we're very honored to lead this with CUNY School of Public Health, and then working hand in hand with the Department of Health and Mental Hygiene, as well as with Economic Development Corporation of New York City and Emergency Management. And I think it will be interesting to think about some of these lessons that I mentioned, that how these can be incorporated into the work that we can do jointly together moving forward. So just some conclusions. As you know, probably that new outbreaks, new epidemics, and other major public health threats are inevitable. This is not going to be the last. We're going to face other health threats. It's inevitable. There are important lessons, and some of these lessons will need to be learned and embraced as we move forward. No magic bullets, need to have all those biomedical as well as behavioral and structural interventions. And then lastly, that effective prevention, preparedness, response, and recovery from pandemics or other health threats requires centering the efforts around early and ongoing engagement with communities. And that's it. Thank you very much.
Thank you so much, Wafaa. That was extraordinarily clear, and you know, one thing I appreciated from the last week being away, and something you did very nicely here, was giving our staff and everyone watching a chance to step back and to see the bigger picture. So often our teams are just so deeply engaged in the work that being able to frame this as a bigger set of intersecting issues is welcome. I think it's a welcome opportunity to step back and see some of the challenges that we're facing and the commonalities. As someone like you, later on though, who came up during HIV, at least the era of HIV around treatment equity and treatment access, so many of the lessons learned from that time are still applicable today. So I guess my first question is, as you think about these three sentinel diseases and the story they tell about our preparedness, our willingness to respond, our ability to respond, are you optimistic, or do you feel like we're repeating similar patterns and mistakes of the past? And how do you see us directionally?
Interesting. It's interesting. I am fundamentally a very optimistic human being, so my team, I'm the eternal optimist. So I need to preface it by saying this. I think it's. I think there are people like the people in this room who are very cognizant of the lessons because they've lived and they've lived them. You've lived the experiences and so on. I think the issue is what power do we have to influence the ecosystem around us? And I do think that's where some of the lessons that we have learned, you've learned, I've learned, every person in this room has learned in their career, They're very durable. You don't forget them. I mean, they're very, very powerful. But I think often, either because of external circumstances, because of the inattention of others, because of the shifting priorities that happen, is that they kind of forgotten or never embraced. So I do think that, I personally think that one of the silver linings of COVID-19 is maybe there's I believe there's much more appreciation of what public health offers. And that makes me very optimistic. I think also there's much more, I believe, public health literacy in the population overall. I'm amazed that people who have nothing, have never studied epidemiology or public health or anything, that they know now when they look, they know what is a case, they know the difference between infection and disease. They know that you need more than one dose of a vaccine. They know that waning of it. It's kind of amazing how much, I think there's been permeation of knowledge about public health, and we need to grab that and somehow and take them. And how do we grab this moment? I think that's what we're hoping, obviously, with PRI and working partnership with you, is how can we not lose the momentum from this moment and take all those lessons, because we've learned them, but how do we impart that on kind of the path forward?
Yeah, I think it's a perfect segue to my next question, which is around partnership. The P in PRI, I think, actually should be around partnership, because if we've learned nothing from COVID, mpox, HIV, is that one sector can't do this alone. And in fact, one of the things I remark often to my most proximate team is how much of a groundswell of interest there is in partnering with us from the private sector, from the nonprofit sector, from just all walks of this incredibly complex and diverse city and well beyond the city. But some of it is around how are we able to organize, align, get everyone on the same page. During COVID, during a crisis, it seemed everyone was relatively on the same page. Get people vaccinated, get people treated, tested, treated, protected, get them life-saving PPE. Those seem like a set of goals in an emergency that we can all get our heads around. How do you see the future of partnership, alignment, organizing across these myriad stakeholders that you bring together at PRI, that we interface with? What's the role of government in that partnership? And what's the role of non-government sectors in that kind of partnership?
I think everybody, like you said, everybody's critical to making this happen. I do think, I mean, some of it is appreciating maybe the importance of maintaining the momentum. I think that people, like you said, in the crisis, there's a lot of coming together. I think what happens when there's no crisis is people go back to the usual state of being. And this idea of being perpetually mobilized, we call it, perpetually active, not to be lulled into those moments of wilderness until we hit the next crisis. And how do we work with all these sectors to, in this moment, the peace in between the crises, and to keep them in perpetually in action is a challenge. I do think there's interest. I mean, as you know, we brought together maybe 50 or 60, maybe 55 groups from community groups from across the city in a one-day conversation, and it was remarkable. I think that the insights they had about the response, it was very positive too. It wasn't like pointing fingers. It was more, how can we do things better? And they are thirsting for this continued engagement. They're thirsting for continued engagement with the government, with public health, like with the Department of Health. They're thirsting for engagement with academia, with the corporate sector. So they want the engagement. I think the onus is on us, in a way, is how do we make it possible for them to remain engaged? They want the engagement. Some of it is resources, obviously, is that we don't invest enough in keeping these organizations engaged, and they're really surviving on a shoestring. Is how do we think about them as true partners, meaning sharing resources? You know, it just requires a completely different shift, mind shift, But I think it's doable. I think if we sit together and we think about whose role is what, and people know what their role is, and they know that they're respected for their role, they'll be supported for their role, I think we can make it work. But again, I have to say, it is still about the resources and how do we secure the resources that are needed, and how do we maintain the resources so that people continue to be engaged, continue to be interested. But I think it's doable. I think that we just have, it requires work.
Yeah, I think it requires work. It requires also, in a way, you need an entity like government to set the rules.
Right.
But that doesn't mean we have to do everything ourselves. We can't, right? We can't do everything ourselves, as we've always known, and as we learned in COVID. We rely so much on our partners in communities, in healthcare. But when they're not organized around a common vision, then they're off doing their own things and telling their own stories around success. Even though at our level, when we're looking at the data, we're not necessarily seeing the same success that they're seeing. So that's something I've definitely tried to emphasize here as the strategist for the city, right? Strategy sounds kind of heady and far removed from people, but if you want organizations and institutions to work in coordinated ways on behalf of people and to impact people in communities, you need a sound strategy, and public health is in a perfect position to see the whole picture.
I mean, it's interesting because in PRI, the goal is to establish these, to have like a headquarters, but they have these borough hubs, a hub in each of the boroughs. And the idea is exactly what you're saying, is that these hubs will serve as, these will be run by community-based, someone or community-based organization. But the idea is that they would be a conduit to strategy, knowledge, information, in a bi-directional way, coming towards the community, but also to disseminate the information, but also how to garner information from these communities so they can inform the work of government. So that hopefully these hubs will enable this kind of bi-directional communication that we're seeking, or you're seeking, so that the communities have the correct information and the community groups are able to act on it. But also they feel a partner in terms of bringing back information. And I think that will enable them to feel particularly powerful and maybe appreciated. If they feel they have a certain connection, and that they have essentially they have a conduit to all of you. I think that's another way, is that feedback loop. Often when you talk to these community groups, they feel they're being talked at, or they're expected to disseminate things, but they have a lot to tell us, and hopefully putting in place these structures and channels, maybe that will help as well.
Agreed. And we built a lot of that during COVID, yes. So it's our challenge and maybe the PRI is one of those vehicles we can leverage. So switching gears a little bit to what we talked about on the global front, yes. The pandemic treaty. What are you particularly paying attention to? You mentioned commodities access, vaccine access. There's a number of issues that were discussed in the broad conversation around the treaty. And obviously there's more negotiations happening behind the scenes. What are you paying attention to particularly? What are you optimistic about? What are you cautious about? We've tried this before, of course. So what are you paying attention to?
I wish I could ask you that question because you're the one who's there. I think part of I think we have to be somehow, the word preparedness sounds so glib and easy, but we can't have one country that's fantastically prepared and others that are not. I mean, this idea is that the sharing of responsibility, the sharing of information, and the commitment to that is very important because we've learned we're completely interconnected. HIV, mpox, COVID-19. We're so interconnected. There's a way in which there's a frank and honest sharing of information, and then also a commitment to working together to have a prepared world, not a prepared United States or prepared Europe, but sort of a bit more of a, I always say that one thing I've learned from HIV and having been a PEPFAR implementing partner, PEPFAR is the big funder for global HIV programs, is you sure had metrics. You knew what you had to accomplish every quarter. It wasn't every year even. You had very clear metrics ahead of you, and I can't tell you how important that is, how important it is for a country, how important it is for us working PEPFAR, is having those kinds of, something else that I wish is having some kind of a concrete metrics that we collectively as nations around the world say, we are going to commit to do this by, and true commitment, by X year, by the end of this year, by the end of next year. So I think one of it is sharing information is one important aspect. Another is having really measurable, very concrete measurable milestones that everybody's committed to, and then some ramifications if you don't reach those milestones. That's a big issue. And then, of course, the other issue is equity in terms of sharing resources and sharing tools and innovations.
Yeah, I mean, I think much of what you described was discussed. I think the issue of resourcing, obviously there's a pandemic fund that's also being resourced, and the United States has thankfully put in significant resources. I think it's around 700 or 800 billion at this point. So that's a pretty good sign that we care on that front. Sorry, million, not billion.
Yeah,
not billion, million. That was ambitious. But I do think it is really a testament to how difficult these problems are in a world where we are, while we know we need cooperation, self-interest is coming back. Nation-state self-interest is very much coming back to the fore, whether it's around collaborative surveillance and data sharing, or commodities equity, vaccine equity, treatment equity. I was sitting across the table from the Minister of Health or the Health Secretary in Kenya, and they have less than 10% of their population vaccinated.
Yes.
And as we all know, that then becomes an incubator for variants and viral evolution, let alone the moral imperative of protecting human beings. And so on that front, it does sometimes feel like we haven't learned our lessons from HIV. And we really do need some collaborative investment to protect upfront the communities that need our extra investment and extra attention. And so, and the nations that need our extra investment and extra attention. So I think we have a lot of work to do. I think they have an ambitious timeline of finishing this treaty by next year. I'm doubtful, but I remain, as you, optimistic that we can come up with something. In the opening of the assembly, the former Prime Minister of New Zealand said, we will be judged, Jacinda Ardern said, we will be judged not whether we do something in the aftermath of COVID-19, but whether we do enough. And that's really a really important question of whether we'll do enough. So I don't know, I think we're out of time. Do we have any questions from the audience? Do we want to take one or two before? Yeah, let's try for one question from the audience. Anyone want to ask Wafaa a question? Yeah, please. I can't get up.
I'll do it. I'll do it.
Thank you, Dr. Al-Sadr. In your presentation, you showed the Global Health Security Index, and you were critical of its metrics. In your opinion, if you could pick 3 to 5 domains or categories to include in a revised index, what would they be? And also, is there any country that you admire their COVID response and would look to as an example?
That's a tough one. It's hard to, as an individual, I think we need to pull together, like I was thinking this might be a nice project for PRI, working with you here, to think about the metrics. I mean, I think some of them, like trust, it's fascinating that trust came up and as the #1 factor. I don't think that the metric itself, the index currently includes things as subtle as trust. Issues around community engagement, community channels of communication. I just think we need to take all those lessons and sort of map them and say, okay, we have data now that tell us that these are very important variables that need to be included. I think we need to do first an analysis of what's in there, because it's multi very different dimensions and buckets that they look at, and think about really where we missed the boat. And we can use even we can be self-critical, use the United States as an example, and see why did we score so highly, and how did that not really match with our response in terms of how we did. So I think it requires doing kind of a look back, doing a deep dive into what are the measures that exist, and then doing a deep dive into what have we learned, and then trying to come up with some other measurable metrics that moving forward. I mean, I think I've heard this said not by this Department of Health, but by others, is that there have been so many, that it's possible to go back and look at what they measure and say, wait a minute, that's helpful, but that's not the most critical factor. So I think it requires I would be guessing if I thought of three things off the top of my head. Trust comes to mind. I think very, very important. It's not just in this country, but all over the world. In Sub-Saharan Africa, countries that had where there was mistrust of the government, they had a huge issue in terms of vaccination coverage, because people just they felt that there was a conspiracy and so on by the ruling party. So I think it might be more subtle things, but we need to examine this.
One last question?
Yes.
Julian.
Thanks for that. I think in your talk, it seems like you were getting at this thing, like it sounds like we need an intervention. It sounds like we have all of this knowledge and all of this infrastructure, and yet when it's time to apply it, we produce, like we get in this cycle. And I think one thing about the trust bit that I find so important to the work that we do, in our bureau, is asking that question about not, how do we get their trust? Like, how do we prove ourselves trustworthy?
Yes.
Because we started our community engagement with the vaccines after, at the very end of 2020.
Yes.
And so communities lived 2020, saw the results, and then we go to them, responsible for the response, and have this amazing gift to offer them. But based on the profound amount of evidence, we see that they've been betrayed, they've been failed over and over, right? So this question of how do we build trust, I think it's more about this foundational, fundamental thing. How do we as a discipline look at what we do and what we have done? And why is it that these things that are unnatural are rendered almost as if, just the hand of God, right? How is it that the first stress test after COVID-19, mpox, that we felt the same communities with similar modes of transmission, all of what we know about HIV, we go into this thing colorblind, racially, no racial consciousness. We go in there not understanding how the lived lives of these communities, like everyone is an MSM in 2023, we know, and so there's this big fundamental question I think that we all have to ask ourselves in the field, and I guess it's not a big question for you, but it's like, how do we actually do this? How can we rescue this field from this dark age thing where the medieval ideology of white supremacy is the ghost in the machine that we can't even mention, we can't even speak to it? I think our discipline, we don't even have a way to look at this thing.
I agree, and I think one thing is, maybe it's in the rush you started by saying at the beginning, is that it's like sometimes we're just acting and we're trying to do the day's work, compartmentalizing and stepping back and taking a moment and saying, okay, what's likely to happen and not happen? It's almost, it feels sometimes like it's a luxury. We knew, like you mentioned, COVID-19 vaccines. I think everybody who knows coronaviruses, we knew we were going to have a vaccine. This is not HIV. It was we were going to have a vaccine. But the question is, why didn't we start thinking, in April of 2020, we're going to have a vaccine, let's plan for it, think about it, who are the right people to be. We don't we don't do that well. You know, we tend to kind of focus on what the task is of the day. And we need, you know, we need people like you and other people to say, wait a minute, I think we're about to fall into the trap again. And to say, hold on, what are our principles? You know, what are the fundamental ethos of? I remember when we started, like I said, let's stop and think about what is going to be our ethos in terms of trying to scale up treatment, HIV treatment in sub-Saharan Africa. And we came up with 5 different things, but it was important to take a moment and say, we're going to trip along the way, but let's at least put some key kind of principles that we're going to try to stick to and remind each other of it. We're not perfect, but I think we can trust each other to be partners for each other, to remind each other when it's time to do this, that important reminder.
Very well said on both accounts. Thank you, Julian. Thank you, Wafaa. And let's give another applause. Thank you to everyone in the audience. How many people are tuned in? How many people do we have? Oh, we have a lot of people. Thank you for tuning in, and we'll see you next month at the next
Wonderful to
series.
see people in person.
Yes.
Here. That's